Good morning. Thank you, Edwin, and thank you all for being here this morning to see the last few talks of what has been a fantastic meeting. At UVA, we have general research support from Siemens, and I'm an educational speaker for Philips on ultrasound. I want to start by acknowledging all the people who've contributed to the images you're going to see, and special thanks to the people who contributed slides from outside of UVA. All of the work I'm going to talk about was done at UVA if it's not otherwise specified. So I'll talk quickly about the burden of lung disease, how we evaluate lung disease, the challenges in the field of hyperpolarized gas MRI, and then I'll spend most of my time on assessing treatment effects with hyperpolarized helium MRI. I don't think it's enough anymore for us to show the disease. We have to show that we can have an impact clinically. So COPD is the third leading cause of death worldwide, and if you look at the two causes of death below COPD, they're both involving the lung, and so really if you added them up, we'd almost edge out ischemic heart disease. COPD, up until quite recently, there were very few drug treatments for lung disease that did anything other than ameliorate symptoms. But there have been major breakthroughs in a few diseases recently, and there are quite a number of diseases or drugs under development, and these have very new and novel mechanisms of action that may really change how at least chronic lung diseases are treated. What do we have to evaluate lung disease? Well, there's the old standard listening to somebody's lungs, pulmonary function tests, and then imaging. Pulmonary function tests are really the standard that are used to judge how severe someone's lung disease is and whether a drug affects the lung disease. And it's just blowing into a tube and measuring flow volume curves. The nice things are that they're very widely available, it's inexpensive, easy to administer, the FDA in the US accepts it, but the big problems are that it's insensitive to early disease, it's insensitive to small changes in disease. Certainly there's huge issues with reproducibility. If a patient doesn't give as much effort, you won't get as much flow, and young children simply can't do it. CT shows structure in exquisite detail. Nuclear medicine shows function, but with very poor temporal and spatial resolution. So there are very few really remaining indications for a nuclear medicine ventilation scan. MR with inhaled contrast. We can get these exquisite images of the gas distribution in the lung. We have a very high temporal and spatial resolution compared to other functional lung techniques, but our big challenge is that it's not yet approved for use. And of course there's Proton MR, which it's been a very exciting meeting. The two lung sessions have had quite a lot of interesting talks on advances in Proton MR. So why are we still standing up here on a Friday plenary with hyperpolarized gas 20 years after the first images were obtained in 1994 by Mitch Albert and collaborators. By 1996, it was quickly translated into humans. So in 2 years, we went from imaging dead animals to humans. By 1999, we were able to routinely perform helium MRI. We had techniques for ventilation, soft tissue, short timescale diffusion, and multi-breath hold PO2. By 2008, we had parallel imaging, long timescale diffusion, single breath PO2. So the technical developments were going terrifically. By 2014, we could do simultaneous hyperpolarized gas and proton acquisitions. We had the direct dissolved phased imaging with xenon, and just excellent quality with both gases. Now we have a wide variety of different tools that we can use with this. So technically we've been terrific at advancing this field, but it's not yet a clinical tool except for in Sheffield, which is really fantastic that Jim has managed to do this. And the real stranglehold was done by some of the companies that ended up owning the IP for the hyperpolarization technology, which they ended up purchasing sort of accidentally along with other IP that they wanted. But now gas polarization systems are commercially available. The next challenge was after 9/11, the stockpile of helium-3 went rapidly down because it was used in neutron detectors. But we, as a field, switched to hyperpolarized xenon by improving the polarization technology and acquisition techniques. I won't go into the details, Jim already did this, but the main thing that you can do with xenon that you can't do with helium is image that dissolve phase, but the diffusion imaging, the ventilation imaging can be done with both. And here's just an example comparing different patients, but ventilation imaging of helium and xenon. So the real challenge, and this is challenge number 3, is regulatory approval. And at least in the US, we've been told that we have to demonstrate clinical efficacy. Not just that we demonstrate and show disease, but that we have an impact on patient care. And the problem has been that there were actually very few treatments for lung disease that altered the course of the disease. So if I can detect the disease early, but there's nothing to be done about the disease, I'm not having clinical efficacy. So the focus of my talk is going to be showing you ways that we influence or detect the effects of treatment. So I'm going to talk solely about ventilation, but I acknowledge that there's been tremendous work done with the other techniques. So if we have someone inhale one of these gases, hold their breath, we take an image, we see where the gas distributes, and in obstructive lung diseases, areas of the lung don't get gas and they appear as dark, or we call them defects. So let's talk quickly about cystic fibrosis. It's a relatively common single gene disorder. It affects about 30,000 children in the US. There's over 1,500 different CF mutations. So this is a perfect disease for designer drugs. And the fundamental issue in CF is that the CFTR protein is a protein that goes to the cell surface. It's a chloride channel. When you have CF, it doesn't open correctly or it doesn't form correctly, and so your mucus is thick, and that leads to repeated infections and death. So if we do just static ventilation in patients with cystic fibrosis, you can see the more severe, the lower their spirometry, the FEV1 is, the worse their lungs look, the more of their lung that doesn't ventilate. This is beautiful work done by Mitch Albert, looking at the repeatability. So if you take the same CF subject and you image them week after week after week, what happens? Well, there's some subtle little changes, but basically where they ventilate and where they don't stays pretty much the same. So over the course of at least a month or two, the imaging's pretty stable. He also, he did a very nice study looking at a conventional treatment for cystic fibrosis. So these patients are prone to infection. They'll be admitted to the hospital. They'll be given antibiotics and what's called pulmonary toilet, where actually you just have somebody pound on their lungs to try to break up the mucus. And he found that post-treatment, you can see that subtle little area in the left upper lobe ventilated a little better. So there was a tiny treatment effect, and not all patients showed it. So this is really an exciting thing. This is a drug, it's a small molecule, and instead of trying to cure a genetic disease by fixing the gene, they said, why don't we try to fix the mutant protein? So they have this small molecule that goes in and wedges into the mutated chloride channel and opens it up. In essence, curing the disease. The problem with this drug is that it only works for one of the 1,500 mutations. It affects only about 3 to 4% of patients with CF. But for those patients, it does go in and it wedges it open. So we did a study looking at patients at baseline, cystic fibrosis patients, and then after 4 weeks of treatment with this oral 2-time-a-day pill, and you can see tremendous improvement in the lung ventilation. And you can see 2 weeks after we removed the treatment, their lungs are starting to reverse quickly. But if you look at the pulmonary function tests, the FEV1 improved from 62% to 83%. You didn't need my expensive helium MRI to know that this drug was working. It had a huge effect on pulmonary function tests. But what about this patient? This patient had normal spirometry at baseline, and yet you can see that there are certainly areas of the lung that aren't ventilating. After 4 weeks of treatment, they really did improve. And you can see that very dramatically on the images, but the FEV1 didn't improve. They say that because of the variability of the test, an improvement has to be 5 points before it's considered a real change. So in 8 patients, we found a bigger effect size with the imaging than with spirometry. And the reason why it may be important, lung imaging may be very important, is that these new treatments are incredibly expensive. This treatment we just looked at is $300,000 a year for a 2-pill-a-day drug. And so what if a patient has another mutation in CF that in theory this could work for? You'd like to know whether it really does. This could be the kind of individualized medicine that we need. And if it were my baby who had CF, I'd want to start my baby on this treatment early, but we have no way of knowing whether it's effective. We don't even have a way of knowing whether they have effects of the disease early, but there is certainly some data to suggest it. So one of the things that we worked on very hard was to be able to do hyperpolarized helium MRI in non-sedated young infants. And here's one with CF, and you can already see a ventilation defect at only 14 months. So I'm going to quickly switch to asthma. It's also a disease that this one's very common. It affects the airways, they're hyperreactive, they get thickened, and too much mucus. So again, if you just look at a cross-section of asthmatics, we do see that as spirometry is worse, their imaging tends to look worse, but it's not a one-to-one correspondence. And if we do provocations, so some asthmatics are very sensitive to exercise. When they exercise, they feel like they're wheezing, that they can't get their breath in. That's why they do the bronchodilators in advance. And we could see that very nicely here. And if you treat patients with albuterol, a known bronchodilator, we can see improvement in lung ventilation. This was a very nice study done by the Robarts group where they did exercise-induced bronchoconstriction on 2 different days. And what I really want to point out here is that when you did the bronchoconstriction on different days with exercise, the same area of the lung constricted. So this is not a random process in the lung. And we saw that in CF too, that when the disease started reversing back, it was in the same locations. And at first I was very surprised by this, but as I thought more and more about it, it makes sense that some areas of the lung in a disease like this that is, at least in some component, immune driven is regional, and some areas of the lung are in some sense more asthmatic than others. And so this was very nice work by Sean Fain's group at the University of Wisconsin, where they said, well, if that's the case, then if we did bronchoscopic sampling of the tissues and fluids in the areas of the lung that have ventilation defects versus the areas of the lungs that look normal, we should see a difference. And they did. In the same patient, if you looked in the normal appearing lung versus the areas of the lung that have defects, there were higher inflammatory cells. So that has a lot of implications, including a lot of studies have been done in asthma with random bronchoscopic sampling or sampling of just the right middle lobe, but you're not really looking at the disease. So you might need a technique like this to guide you. Then there's a new therapy that was recently approved for asthma, and it's bronchial thermoplasty. And so what they do is they take a bronchoscope, which is like a little endoscope. They put it in through the mouth into the airways. They thread it into the airways. They open up little metal prongs, and they RF ablate, i.e. burn, the airway. And they go through, and eventually they burn all of the major airways over 3 different sessions spread over months. Now, this is really quite an expensive therapy, as you can imagine. There's some controversy as to whether it works, which it appears to. It appears to reduce exacerbations, and why it works. If you just burn one spot in a fairly central airway, why would this ameliorate asthma? And some people believe it's because you're actually causing denervation of the smooth muscle that's distal to it. Plausible. So Jason Wood's group has said, well, so we know that asthma is a regional disease now. What if you direct the bronchoscopy and the bronchial thermoplasty to the most affected regions of the lung first? Might you be able to, instead of having to undergo 3 bronchoscopic sessions, have them get the same effect with only 1? So really reduce the cost of treatment. As a first step toward that, he simply looked at patients before and after bronchial thermoplasty to see whether he could see the effects of treatment. And in this patient, there was a large effect, although that wasn't the case in all of the patients. The Robarts group is also looking at pre-post bronchial thermoplasty, but what they did, which was very clever, was they also did methacholine after the, both before and after the patients had the bronchial thermoplasty. And you can see there wasn't too much change in the baseline appearance of the lung, but it really did reduce the hyperreactivity of the lung to methacholine. So that's a very interesting result. So I just wanted to quickly mention our 4th challenge in the field, and that is pulling quantitative information out of our images. There's been quite a lot of work done in the image processing domain to pull out quantitative imaging, but I also wanted to just mention some of the nice work that's being done of doing the quantification in the image acquisition domain. So at UPenn, they're doing a multiple breath wash in, and you can see in this one patient where first breath, second breath, or I guess 4th breath, 7th breath, that the lung fills in more and more and more, and by quantifying that, they're able to get fractional ventilation maps, which are inherently more quantified than just the single breath ventilation images that we've been getting. Jim Wild has been doing multi-breath washout imaging, so the same idea, just done in a slightly different method. And I'd also like to just compare the hyperpolarized gas imaging with some of the nice work that's being done with proton lung. And of course, we all know proton lung is very challenging. Low proton density, short T2 star, lots of motion. So using UTE sequences, which was the topic of a number of sessions, we can pull back some of the signal. We can at least see some of the structure. But what's been interesting to me, several groups have done this. This is work done by Sean Fain's group at Wisconsin, doing the oxygen-enhanced imaging that was first described by Edelman's group in the mid-90s. But if you have greater signal in the basis images, can you get better images doing the oxygen-enhanced? So you have you acquire a UTE image when they're breathing room air, and then after they're breathing oxygen, and do a subtraction. And so here's a nice comparison between helium in the top row and oxygen-enhanced imaging in the bottom row. And you can see there's really awfully good concordance, at least in this patient, and this would be something that could be done in any hospital anywhere without additional FDA approval. There are some issues with the oxygen measurement, that it's measuring both ventilation and perfusion, but there's nice work going on trying to separate that out. So in summary, we're able to detect lung pathology in ways that were not previously possible. We're also, and I think importantly, able to detect the effects of treatment both in individual patients and perhaps for drug discovery and drug assessment. And our final challenge here is regulatory approval. And again, I'd like to just say I think some of the proton lung images are just really very promising. So thank you very much for your attention.